Welcome everyone, I hope you can hear me all right. My name's Rachel, I'm one of the in-house vets at BCF Technology, and I just want to say thank you very much for signing in this evening and joining us for our next webinar, which is with Peter May and has a bovine reproduction topic. Peter qualified from Glasgow University in 1983 and began his career at his local practice. 2 years later, he then bought into the veterinary partnership. In 1993, he became the first vet in the UK to treat repeat breeder cows with IVF embryos and offer bovine fetal sex determination to clients. In 2004, he then completed the DBR and started consultancy work abroad. He now works as an independent consultant as well as closely working with drove farm vets. He's a partner in Active Vet, with current work ranging from routine fertility and embryo transfer, IVF further afield, and embryo transfer, IVF and ultrasound, training both in the UK and abroad. Throughout the webinar, there will be a few opportunities to participate in a quick survey. It's anonymous, so please do take part by selecting and submitting your answer on screen when the opportunity arises. Throughout the webinar, please also feel free to ask questions. You can do this via the control panel in on your screen facility, and we'll then log your questions and go through as many as we can with Peter at the end. If you want to be anonymous, then just say so before typing your question. So without further ado, I'm going to hand you over to Peter. Thank you, Peter.
Well, good evening, everybody. And first of all, thank you very much for joining us. Thank you to BCVF for inviting me to present this webinar to you. For the next 40 minutes or so, what I'd like to really do with you all is share my reproductive scanning over the last 30 years. And I'm just going to have a fiddle with this computer. You're the presenter. Yeah, that's fine. Okay, that's fine. And I just want to get rid of that screen there. Let's get rid of that. There we go. Okay, so the webinar is going to be divided into different sections. I'm going to start off with dealing the stages of the reproductive cycle. Then we'll look at aging the bovine fetus, fetal death, twinning, set scanning, and at the end, just some of the latest things I'm looking at. To start the webinar off, I was going to ask you all a question. So in your cattle fertility work, what is normal for you? Scanning, manual palpation alone, a combination of scanning and manual palpation, or neither. I think someone else might have put that in there. But if so, Rachel, if you could launch that poll, and then you can feed back to me what our participants are doing, and then I'll know what's going on. Thank you.
I'm going to do that, Peter. I'm just double checking. I can't actually see your screen. What slide do you have on at the moment? Have you started the presentation? Peter, can you hear me? That's better, I can see it now, great. So that poll should have been launched for you all, so if you could all pick an answer in the next 20 seconds or so, that would be great. Give you a few more seconds. About 75% of you have gone. Okay, I'm going to stop it there. So, Peter, if you can hear me, the results are 22% scanning, 8% manual palpation alone, 68% combination of scanning and manual palpation, and 2% neither.
Okay, that's great. Thank you very much. And I'm glad to see actually the majority are using a bit of scanning and palpation. And when I started many years ago, I was obviously just doing manual palpation, and when scanners came along, I started using those as well. And I've realized over the years, as I've got into doing more like embryo transfer work and things like that, how important manual palpation actually is. So I'd just like to describe you some of the manual palpation technique I use, because I hope it might help some of the younger people listening to improve their techniques as well. So basically speaking, when you go into the cow's rectum, the reproductive tract, the uterus is lying away from you, and the horns are actually coiled over on top of themselves away from you, such that the distal horn is sort of lying underneath the body of the uterus. And a bit like the handlebars on a racing bike, turning away from you and underneath. And what I'd like you to be able to do is flip that uterus up. And by that I mean you want to be able to flip those uterine horns right over so that they come up and face towards you. And so it's like, if you can imagine turning over the handlebars on a racing bike so they flip up towards you, and it's exactly that. So to do that, I'm a bit of a left-hander, so I'm going in further than you need to, then come back down onto the repro tract. Find the broad ligament on the left side and get underneath that broad ligament and get your fingers underneath the left horn. Start pushing it and lifting it away from you a little bit. And if you've got a small reproductive tract, such as in a heifer, you'll probably find you can flip the whole lot up, side down into the pelvis just by doing that. With a bigger and deeper cow, you might need to bring your hand from underneath when you started unfurling to the top of the uterine body. Feel for the dorsal and then the more prominent ventral intercorneal ligament. With your middle finger, get underneath that and pull it back up towards you. As it comes back up, you can then place your left hand further down the right horn and grab the dorsal wall and bring it towards you. You can do that in several movements. Before you know, you've got both horns facing up towards you. And then you can easily feel one ovary, pull it out the bursa, all the way from the small tip of the uterus to the intercorneal ligaments and all the way along to the other ovary along the other uterine horn. I feel once you can do this, you'll be very adequately placed to be able to put your scanner exactly where you want it to be on the reproductive tract. And this, I think, is very important. When you're starting your scanning work as a young vet, you don't want to miss a pregnancy, a small pregnancy in the distal uterine horn. And as you get into the more advanced techniques, such as SET scanning, I want you to be able to place the scanner head very close to the bovine fetal body so that you can easily see exactly what you want to see rather than trying to scan from a distance. So there we go. Good luck with your palpation and your scanning. So we'll start now with the observations during a normal estrus cycle. So obviously at estrus, we can see a large ovulatory follicle between 1.5 to 2.5 centimeters. And this suppresses the other smaller follicles, so not many others. Near ovulation, you've got hyperechoic acoustic enhancement at the top and the bottom of the follicle. You have mucus in the uterine lumen, which is either present as a hyperechoic streak or hypoechoic fluid, maybe up to 50 millimeters diameter, very, very similar to an early pregnancy. You will have some uterine oedema, a regressing corpus luteum, and as we've been talking about palpation, obviously you can feel the tone, and if you want to do a vaginal examination, which I think is great as well, you'll be able to find mucus and a slightly dilated cervix, feeling slightly swollen in the edematous as well. So here's a picture of an ovulatory follicle, and what I'd like to show you here is a little bit of hyperechoic acoustic enhancement just prior to ovulation. Now, here's some hypoechoic fluid in the uterus about the time of estrus, and here we can see that hypoechoic fluid. And also, interestingly, I can see some edema between the endometrium and the myometrium. This black line here is some edema here, indicating that this is estrus mucus. Here's a very similar picture with a similar sized amount of hypoechoic fluid, but this cow is pregnant. And on this occasion, we have the hypoechoic fluid in the lumen, but we do not have edema between the endometrium and myometrium. And also, if we scan carefully, as you all do, we will find the pregnancy, the fetus itself, within the uterine lumen, within that hypoechoic fluid. Here is the hyperechoic streak I was talking about. So where the hypoechoic fluid is sort of squished down within the uterus, the meniscus comes together, and therefore you get this sort of hypoechoic streak in the middle of the uterine lumen. And I can see excellent uterine edema here around the time of estrus between the endo and myometrium here and outside the myometrium here. So we've got some lovely changes to look at around the estrus period. This is some work done by Heinrich Vollwein from Germany. Became a bit of a friend, and he shared some slides with me, which was very kind of him. He had a little look at with a little bit more detail with a scanner at around the time of AI to see if by extra sort of scanning he could improve conception, and he found a few factors that were useful. Firstly, follicular size. Between 12 and 22 millimeters on examination and CL less than 15, so a nice big ovulatory follicle and the CL shrinking away, 10% better AI if AI at that time. He also measured endometrial thickness and found that a thickness of between 8 and 8.7 mil again gave a 10% improvement. So here's some of his pictures showing how to measure things. And remember, between 12 and 22 mil for a big follicle and a regressing CL, better chance that she's actually in season, ready to serve. And here's measuring the endometrial thickness. So we're measuring between the actual, the lumen and the junction between the endo and myometrium, which at the time of estrus is really clearly demarcated with this edematous line. So we can see the endometrium is a little bit thicker here than would be expected around the time of estrus. So these are the different stages of the cycle and the different reasons why the endometrium might be thinner or thicker. So when we're in estrus, between 8 and 8.7 mil, thinner uterine wall, obviously, through the estrus cycle. Okay, we've said it's edematous at the time of estrus, and here we are, it's thicker. But if it's thicker than that, we may have endometritis. So I think that just shows a little bit more that you can do with your scanner around the time of heat. This is just a simple slide to show you some endometritis, and if you look inside the uterine lumen, you can see some hyperechoic particles. If you're dealing with anything more than 2 millimeters in this area, you should be suspicious that something's going on, particularly if there's hyperechoicity there. Met estrus, we move on. So, it's just ovulated, we've lost our big follicle. Absence of a well-formed CL. The corpus hemorrhagicum itself is basically a bit of a blood clot, difficult to see, but we still have the marked uterine edema, the black line between the endo and myometrium. So here's a corpus hemorrhagicum, and it's a rubbish slide, but look, it's pretty difficult to see, but there we go, there's a blood clot. There's a tiny little follicle on the ovary. Oh, and here we still got that edema persistent. We haven't got the fluid inside the uterine lumen at all anymore, but here we go, here's that edema still present just after the estrus period. So, diestrus, 5 to 18 days. We're now going to start seeing the corpus luteum, very variable structure, can have either a hyperechoic or hypoechoic center. And in general, a hypoechoic center or lacuna tends to fill in as the CL gets older. As I've said, the young CL is basically a blood clot, it's very squishy. The day 7 CL is my favorite one. That's the one I'm always trying to find when I want to put an embryo in. Why is it my favorite? Because it's the easiest to feel. After ovulation, there's been a protrusion of the egg out of the ovary, and there's a little bit sticking out. And at day 7, it sticks out really nicely. In fact, the CL isn't actually taking up much of the ovary inside, but there's a fair bit sticking out. And if you're really lucky, you get a depression in the protrusion, just like a cottage loaf, and a distinct margin where that little bit's sticking out. As the CL ages, it gets older, the margin sticking out of the little ovary gets less, but with your scanner, you can see the CL filling the inside of the ovary much more. With the scanner, we're trying to ascertain really if the CL is functional. Is it producing enough progesterone to be responsive to prostaglandin? So some broad brush guidelines, I'd say the CL needs to be greater than 15 mil in diameter. And if I'm measuring the wall of the lacuna, probably greater than 5 millimeters thick. We really do need a doctor. These are coming now to show blood flow, as this would be a better indication of functionality and progesterone production. We're mid-cycle now, so we do not have mucus or edema or tone, a nice floppy uterus. Okay, so on for some early CLs here. Here's a nice small CL within the ovary, probably a fair bit of it sticking out. But you can see, look, all this is normal ovarian stroma here, so the ovary is occupying certainly under half of the ovary at the moment. Here's another nice young CL, and what we can see in this one is a nice little small lacuna inside it. Here's another young CL, but with a larger lacuna. So here's the hypoechoic fluid, which is perfectly normal within inside the CL, and this is the bit I'd measure with my scanner. Is it less or more than 5 mil to determine perhaps its functionality? Here's the blood clot we talked about earlier, which is hyperechoic inside the lacuna, or hole inside the CL. And here's a pretty one. So this is a bit like a Christmas decoration, this CL. And I think what we've got here is a combination of things. We've got, I think, a blood clot inside and a multilocular lacuna around the periphery. Would this be sensitive to prostaglandin? No, I don't think it would. I'll probably give her a cedar zinc or something. All right, here's a more mature corpus luteum. We can see that this CL is occupying a vast bit of the ovary now, and there's just a little bit of a dominant follicle coming up on the other end. Feeling the protrusion outside of the ovary now will be more difficult. There'll still be a little bump there, but not as much as there would be in the early stages of the corpus luteum's life. Okay, we're moving on now to aging the bovine fetus. I always do this. I think it's a useful thing to be able to do. Measuring the crown rump length. Basically, it's only 4 numbers you need to remember, and they're really easy. So measuring the crown rump length at 30 days, 10 mil, at 35, 15. The next 2 numbers are even easier to remember. 42 days, swap the numbers round, 24 mil. And remember, by 6 weeks, you've got all, it's amazing, all the structures are formed, all the tissues are formed, and you can clearly see the head, body, limbs and tail. Again, another very easy number to remember, 56 days, 56 mil. And at this stage, we can see the genital tubercle. So with those 4 numbers, you can do all your early pregnancy diagnosis aging very easily, and you can certainly tell the difference between service dates 3 weeks apart. As the pregnancy gets older, and the fetus gets further away from you in the pelvis and goes into the abdomen, you will need palpation to help you. So I'm going to describe what I feel as well. I think at 2 months I've got a large salami sausage of a pregnancy. By 3 months, I'm feeling, if you imagine one of those cheap supermarket carrier bags we get now, full of water, and you can still get your arm around the bottom of the carrier bag. By 4 months, I've got a bigger carrier bag, but I can't quite get my arm around the end of it, okay? Between 4 and 5 months, the uterine wall thins and the turgidity is gone. So then when I'm patting down on top of the uterus, it's like feeling a squidgy plastic bag with some mushrooms bubbling about in it. Those are the cotyledons. The amniotic fluid is grainy from 75 days, and that's normal. So we'll have a look at some different ages of fetus. So when I'm talking about crown rump length, there we go, from there to there. And here's the first number to remember, 30 days, 10 millimeters. And here's the next number up, 5 weeks, 35 days. Got a nice amniotic sac there, and crown rump length, 35. 42 days, swap the numbers around, 24 mil. And here we have the fetal head, the fetal body. We can see limb buds, and from there to there, it's about 24 mil at 6 weeks. By 8 weeks, we've got everything here, and we've got 56 days and 56 mil. So if we measure from here to the tail, we have got 56 mil. Obviously, everything's very visible here. We can see limb buds. We can see limb. Actually, there's a genital tubercle there as well. We'll discuss that in more detail later. As we get further into pregnancy, I definitely think you need your palpation. And something I always find is the middle uterine artery. So again, to do that, let's go in too far, pull back, scraping your fingers against the outer wall, and find the curtain of that broad ligament. And then unfurl that curtain towards imagine the edge of the curtain, the leading edge of the curtain, and that's where you'll find that middle uterine artery. And I can feel it, the phrenetic pulse, which is like a cat purring rather than the loved up firm pulse, from about 4.5 months in the pregnant horn. And also in the non-pregnant horn, I can start feeling it from about 5.5 months. From 6 to 7 months, the uterine artery itself is getting really quite big. And I reckon by the time it's time to come to dry off, it's nearly the size of your ring finger, diameter of your ring finger. And to be honest, it's very easy to find, and almost you can put your arm in a long way and just press it, and you can feel it purring against your arm. It's much easier to feel as it gets time towards drying off. The allantoic fluid itself is grainy for the last 3 months. From 8 months, hopefully the calf is palpable. And yeah, I think it's very important to get the correct service date, to give the farmer the correct dry-off date, and obviously to give the cow sufficient time in the transition group to prep it for the following lactation. Yes, I see about 5% pregnancies that have held to the service 3 weeks earlier. Very important, the guy you're working with or lady you're working with has the dates in front of him and said, you say, right, when do you think that is? And you compare what you're seeing with what they're thinking. I've often seen more holding to an earlier service when I've got a new RMS team on the farm. The RMS team are trying to serve more cows, that's how they get their money. But if they're getting too keen on it and I'm getting too many of these, I will mention it, because my worry is that if they're serving early pregnant cows, that they may lose some, as well as some persisting and surviving to when I PD them. I'm just going to give you some of my observations of cotyledons. Some people measure them, but I find that a bit variable according to which ones you happen to stumble across. But I can describe some of the changes I've seen with my scanner. So basically, the young 3-month cotyledon is a little bit like a button mushroom. So that's little cotyledon like a button mushroom there. Oh, the amniotic fluid, yeah, that's grainy from 75 days, and you can clearly see that. There's the amnion, there's some grainy fluid in there. I think I can see hyperechoicity peripherally coming into the cotyledonary structure from about 5 months of pregnancy. And you can clearly see here some hyperechoicity coming in. I love the 6-month cotyledons, they're great, they're easy to see, and you can see this hyperechoicity throughout the structure, so it's sort of coming in right across now, these hyperechoic streaks. That's a classic 6-month sand dollar appearance, I think, to those type of cotyledons at that stage. And towards the end of pregnancy now, here we've got a very large cotyledon, and I can start to see an outer cortex and an inner medulla almost, so that's a really large cotyledon, which with clearly demarcated areas within it. Grainy amniotic and allantoic fluid, so we've got the foot here, grainy amniotic, grainy allantoic fluid there. Oh, there's that middle uterine artery. I mentioned it was as big as my ring finger, and there it is, and there it is pulsing away. So very useful to know, if you're doing pregnancies at all sorts of stages, which you sometimes do, that's a useful guideline. There's no time to dry off. Okay, so let's have a go at another question. So in your normal pregnancy diagnosis, how many times do you check for a fetal heartbeat? Rachel, are you there?
Yes, I'm here, and I'm just going to launch that for you.
Yeah, that's fine. Thank you. Okay.
Hopefully you can all see that. I'll give you about 30 seconds to answer that one again.
Thank you, Rachel.
Still going up quite quickly, so I'll give them another few seconds.
Yeah, no, that's fine. Yep. Just interesting to know.
Okay, we're on about 85%, so I'm going to close it there. Thanks, everyone. So the results of that one, we've got 28% saying none, 22% saying up to 10%, 20% up to 50%, 16% of you between 50 and 75%, and then 14% near to 100%.
That's great. Thank you very much for sharing that with me. It's something I suppose, yeah, I'm trying to get towards 100% now. Why? I feel that my fertility work is the umbilical between me and my large dairying clients. I see them regularly, and from that all my other work comes, the whole picture as it were. And I think I need to add value to what I'm doing. I'm competing with non-veterinarians, I'm competing with a milk test now, and I need to be sure that the fetus I'm dealing with is viable. You can very easily get a lot of hypoechoic fluid, but the fetus instead is not ticking. And if that's the case, the corpus luteum will persist for what, between 100 and 150 days? So an undetected non-viable pregnancy is a very big loss to your client, and I feel it's important that we try and add value to our clients to keep our business ahead. So fetal death, there's a lot of things to see with fetal death, and I'll just run through them and show you some pictures. Less fluid, obviously. A fetus smaller than expected for the stage. That's why you should get used to those measurements and give yourself a bonus point if you get the days exactly right. You get an increased echogenicity, a grainy type of fluid in those uterine horns rather than a very nice dark clear fluid. Most importantly, lack of fetal heartbeat. You can always see it ticking. You can see it ticking at 28 or even less if you want, but 30 days easy. Poor definition of fetal anatomy. Membranes separating and floating within the uterine lumen. More membranes visible. Normally they're stuck against the wall and then they start floating in there. You know there's something wrong. The fetus itself can be hyperechoic. It's also more mobile than usual. When you scan through the pregnancy normally, you'll find the fetus is in a certain point, and that's useful when we come on to twinning. But once the fetus is dead, the membranes are separated and it's floating around a lot more. Pyometra, simple pus in the uterine lumen. I'm sure you're aware of that. So here's some pictures, and here is, some membranes separating, thickened, hyperechoic and swollen. Obviously there's something wrong there. Here's a beautiful little dead fetus. Here we go. So there it is in the middle there. There is a hyperechoic dead fetus, and here is some grainy amniotic fluid, which it shouldn't be at that early stage, and obviously things shrinking away in the small uterine lumen now. No, this is just pyometra. So here's pus inside the uterine lumen. Quite easy to see. Okay, I think this is our final question, Rachel, with your help. I'm going to ask you now, in your normal pregnancy diagnosis, what proportion of you actually check for twins? Are you there, Rachel?
I am here, so I'm just going to launch our last poll.
Yeah, let's go for it. Yeah, let's see how we're getting on.
Do another 30 seconds or so.
Thank you.
Everyone's going super quick for this one. We're at 75% already.
Fantastic. They're getting better.
Okay, we're sitting on 82% and nothing else is happening much, so I'll close that for you.
Okay.
So results of that one, we've got 23% saying none, 23% saying up to 10%, 19% saying up to 50%, 16% saying between 50 and 75%, and then 19% saying near to 100%.
Okay, yeah, that's great, and thank you for being very honest with me. Again, I'm going to nag you, or encourage you, I think, actually, to try and do more. Again, we need to add value. The milk test can't tell the farmer's got twins. We've all seen them on the farm, haven't we? The cow that's had twins, she's falling apart. Why is she falling apart? She calved early. She never got the transition ration, she's got a retained cleansing, she's got a displaced abomasum, and she's a write-off. So we don't want that. And I'll tell you what, my farmers love me telling them about twins. We manage them differently. We can dry them off early, we can look after them better, we make sure they get the transition. And I think that's really, really important, and a very clear identification of your enthusiasm and effort to try and help your client doing a normal job but giving them better value than other people who might be doing it. So 5% is pretty normal for twins. I have several herds over 10%. I find actually the higher producing cow under a greater stress level, I believe, has a higher chance of twin ovulations. They do calve earlier, and I believe they have a higher rate of embryo loss. I've got some pictures to show you on that. It allows us, we must identify them and dry them off earlier. And some of them I do recheck. I check, fetal heartbeats, and I have to go back and see what's going on with some of them. So most twins are dizygotic from 2 ovulations. Only 1 in 100,000 naturally are actually identical twins. How do we detect them? Particularly if they're in the same uterine horn, the allantochorion actually anastomoses, and you get a line of membrane running between the 2 feti. And that's how you get your free margin, where it joins up and the male factor goes across early. You can count how many CLs, and this is really, I think, what we need to do. It's certainly helped by gentle uterine flipping so that you can scan accurately all the way along both horns. So roughly these days, I'm in, Dark fluid, yeah, bingo, we're going to get something. Here we go, let's go through that dark fluid, just following it through, and where the diameter gets to its greatest is very often where I'll find my first pregnancy. Is it ticking? Yes, it is. Right, let's whiz off to the ovary on that side. How many CLs are on that ovary? Just one, that's fine. We're going to whiz over to the other ovary quickly. How many? If there's one there, or if there's two on the first ovary, I must just recheck and see if I can find them. If I find 2 CLs these days, and I can't find 2, I might even bother to recheck them in a couple of weeks. But if I find 2 and they're both ticking well, I just tell them they're twins, and we definitely, on all the farms I'm doing it, we do dry them off a couple of weeks earlier. They often get a Kepstone bolus. They're going to get drenched. You know, we're ready for it. We can manage them better, and they get through it a lot better than they would if you hadn't told him or her. Right, 2 corporal leads here that are easy to see. Here we can go. So here's 2 cells, and we can see, you know, they're definitely well defined with a little bit of a connective tissue septa between them there. And here's 2 CLs that are a bit closer together and more difficult to see. Can you see that there is actually 2 here, but not very clear. So look carefully when you're looking at the CLs to determine if there are indeed 1 or 2. Here's the co-joined allotochorion running between. It's quite a nice. It's a normal pregnancy. It's quite a thick bit of membrane there running through, and you can follow it. I've got videos. I didn't show videos tonight because they sometimes fall over, but I'm doing again at the BCBA another workshop, and I can show you videos there, and you can clearly follow this co-joined membrane between one co-twin and the other. Here's a picture of this is a 2-month viable fetus, okay, and here's its dead co-twin. So if this is a lady, she may be a free Martin, and this one's not going to survive. And in fact, this one did survive and was fine. So, you know, you can see these things going on. Farmer likes to see them as well. They're interested in that type of thing. Oh, here's identical twins separating, and that's about the stage it happens as well. I know that because that's an embryo I put in down on the farm. The farmer took that shot for me. And there they are. Those ones are going to be identicals. Okay. Well, this was just to show you it's worth looking at the detail. And here's a 32-day-old calf, and I saw a normal fetal body here, but then I thought, hang on, what's going on here? So I had a guess at what it was, because a year or so before I had a look at a calf and said it was wrong, and I knew it wasn't right, and it turned out to be a schistosoma reflexus, and I realized actually you can diagnose fetal abnormalities at quite an early age. So I re-scanned this one, obviously at 56 days, and here he is. I actually named it Aching Breakface, and here we have the 2-headed calf, which was diagnosed. So I actually advised the farmer to abort it. He wanted to keep it. He wanted some sort of Victorian circus performance. My fellow practitioners would have been pretty teed off having to do a cesarean section. Luckily she aborted, but she did come back into milk, so that's a happy ending. But you can detect fetal abnormality using your scanner, and it adds a lot of interest. The farmers, you know, they like you picking these things out. Okay, so the next section is on fetal sex scanning. This is something I've been doing for many years now, and I think it adds a little bit of interest. Not commercially acceptable, but if you're doing ET work, I think it can be quite a useful thing to do to help farmers make decisions. So, ideal time, 56 to 65 days. By 56 days, the genital tubercle is located in a position that allows you to determine sex. You can certainly do it after 65 days, but as the fetus gets bigger and goes further away from you, if you get the right bit of the fetus, you can certainly see it all, but if it's too far away, you'll find it difficult to visualize the anatomy. We need to identify this genital tubercle, the bilobed hyperechoic precursor of the penis or clitoris. So at 49 or 50 days, we can see this hyperechoic structure exactly in line with the hind limb buds. But over the next week, the fetal body grows, so the tubercle then becomes positioned behind the back legs, underneath the tail. It's going to be the clitoris, so that's a little girl, or in front of the back legs, right adjacent to where the umbilicus joins, it's going to become the penis, and that one's going to be a male. If you're lucky, you can get all those structures in one cross-section with your scanner, but you do need to learn to scan, because that doesn't often happen, or always. You need to scan through the fetal body and realise which cross-section of the anatomy you're looking at to enable yourself to do this. I believe it's a good idea to gently flip the uterus up to get the scanner head close to the fetus when you're trying to do this. Anyone can interpret the pictures, getting the good pictures that allow you to do the technique properly and easily. We can also visualise the male scrotum. There's 3 hyperechoic parallel lines immediately between the hind limb buds. We can also obviously see the fetal bladder, which helps you know which part of the fetal body you're scanning, fetal teats. And there we go, yeah, adds some interest. And yeah, helps the farmer make decisions about what he flushes that cow next to, if he's got all bulls this time or all girls this time. You know, I think it's an interesting and useful thing to do. So some pictures. Here we start. We're going to start at 50 days. So I've got all the structures in view. Here's the head, the forelimb buds, the big fluffy umbilicus. Quite big, that bit. It always surprises me. And here we have the bilobed hyperechoic gentle tubercle lying in line with the hind limb buds, perfectly in line there at 50 days. So you can bang on get your 50 days there, no problem. Ladies first. So here we go. Again, the head's up here. Here's a forelimb bud, the big fluffy umbilicus, the foot, the hock, the other hind limb. Behind the hind limb buds, here we have the bilobed hyperechoic gentle tubercle nestling immediately under the tail. Perfect little girl. There we go. Now, that was easy with all the structures in one frame or in one shot. This one I've had to gradually scan through the fetal body, and I've finally got to the back end of it, and here we go. Finally we find out it is actually a little girl, because here's the tail, and here just underneath the tail is the bilobed hyperechoic gentle tubercle. So that's definitely a female fetus. There we go. Here's another shot of a little girl. Big umbilicus there. There's obviously the distal limb here. There's the hind limb bud line, as it were, and behind the hind limb bud line is the bilobed hyperechoic tubercle again, definitely a little girl. Okay. Oh, here's a great shot of a little boy. This is, yeah, I like this one. So, forelimb bud. Fantastic shot of the umbilicus. You can actually see the blood vessels, I think, within the umbilical structure there. And here we have the bilobed hyperechoic tubercle immediately behind the umbilicus, in front of the hind limb buds. That is definitely a little boy. Okay, bonus points for a shot like this because everything's there. Here we have umbilicus, well, forelimb bud up here. Here we have bilobed hyperechoic gentle tubercle. Here's a hind limb bud. Here's a hind limb bud, and here are 3 hyperechoic lines for scrotum. There we go, and there's the tail behind. So that's a good shot of all the male anatomy at probably about 60 days, that one. So now looking at the cross-section of the fetus as we scan through the body. Again, I could show you this better on a video loop, but this is for each frame. So here's the umbilicus actually joining onto the fetal body just at this point, this cross-section of the fetal body. And here we go. We've just moved backward off that umbilicus. How do we know we've gone backward? Because we've got the fetal bladder in full view, and immediately behind where that big umbilicus joined on, there is the bilobed hyperechoic tubercle, indicating this is definitely a male fetus. Okay, so that's your set scanning, and here's a few other things, because I think the great thing about our job is we learn all the way through, and I'm certainly still learning loads. Something I think I've recently recognised, but I think this really needs to be looked at in a little bit more detail, is hyperechoicity of the uterine wall. I have observed this a few times now, and I've often found it in cows struggling reproductively. Pyometra is obvious pus in the uterine lumen, so it's more than 3 mil in diameter, and you suspect endometritis if it's 2 to 3 mil. Obviously, combine a uterine scan plus vaginal to check out, as we said before. So here's the hyperechoicity I was talking about. I'm sure quite a few of you guys, girls, are seeing this as well. So here is the endometrium. Here's some hyperechoicity in the endometrium, and here is some in the myometrium. I think this may well be scar tissue from some chronic type of infection there. There's also a little bit of edema actually between the two layers as well, a bit of inflammation going on. Here's hyperechoicity within the endometrium, and you can see quite big chunks of hyperechoicity there as well. These are just other observations, particularly for the people that are starting their scanning journey, as it were. Cysts. You know, it's very easy to dive into a cow, great big cyst, saying, oh, she's not pregnant, we're going to treat her, but be careful. Cysts are initially physiologically present and physiologically functional and physically present. So when they're early in their format, as it were, you're going to get a cyst on the ovary, and the cow will either be an estrus or an nymphomaniac. You won't see other follicles on the ovaries, they're suppressed, and you certainly won't see a CL. After a while, though, it stays physically present, but not physiologically active. So at that point, we'll see follicles start to come and go. We'll see a CL start to come and go, and she may well get pregnant. Another thing I've observed is poor quality looking CLs looking after a pregnancy that quite surprises me. So I've got a picture of a few of those for you as well. So this was a massive follicular cyst on the cow's ovary. But interesting, I scanned through that ovary, on the other side of it, or behind the cyst if you want, was a nice corpus luteum on that same ovary. And, oh, it's a rubbish picture, I'm sorry. But this is the, I don't know, maybe 28, 30-day pregnancy within it, but it was ticking in there, I promise, and it did survive. And so there was the pregnancy inside that cow's uterus next to that big cyst. Here's a poor quality CL with a large lacuna, a great big lacuna, not a very thick amount of luteal tissue there. But here's the pregnancy next to that one that was ticking away quite nicely. So this is yeah, something else I've been noticing recently, and I've learned a little bit more about. Again, Heinrich Bollwein has done some work on this, is counting follicles. You can count follicles of more than 3 millimeters on the cow's ovaries at any time of the cycle. I actually don't think it's quite as good immediately around the estrus period. But what you need to do is count how many 3 mil follicles are on both ovaries and add them up. Less than 15 is a sort of low number. Between 15 and 25 is mid-range, and over 25 is a lot. Very interesting, because this follicular count is related to fertility response, certainly with ET and IVF, but it's also related to longevity, which is fascinating. It's heritable, and a decrease has been noticed in the next generation if there's nutritional stress in early pregnancy, or also if there is an increased somatic cell count. So for me, it's another interesting thing to do. It's an indicator of likely response to ET or OPU. So when I've got a farmer who wants to undertake these type of procedures, and he's got a choice of donors, shall we say, it's great to scan them and see which one's got the most follicles on its ovary to indicate to the client which one's most likely to give them a good response. There are cows out there with 50 or 60 easily, and they are amazing fertility responders, and those are the ones that I think are quite interesting and probably the ones we should be breeding from. Unfortunately, at the moment, I'm doing more IVF on the poor fertility ones than the high score genomic ones with the big ovaries, but I think that will change over the next few years, hopefully. So, I think that brings me just about to a close of what I've got to share with you. I would like to say thank you very much for joining me and BCF this evening. Thank you very much, and thank you to our sponsor, BCF. But I'll hand over to Rachel now, and if I'm lucky, there might be a few questions for me. Rachel.
Thank you so much, Peter. That was a really excellent topic, and I'm sure we'll all agree a really fab lecture. I think we've had 1 or 2 questions. If you just bear with me, I will just open up my tab.
Okay.
First question that we've got is, if you do have a fairly poor CL and you're worried about the pregnancy, do you rescan, and if so, when would you recommend rescanning?
Yes, I do. Most recently I had one, and in fact the pregnancy had faded away. My routine visits are normally fortnightly, and I would normally check a fortnight later, and I've even checked one a month later just to be doubly sure. So normally next routine visit, let's have another look at it and see if it's grown on and see if it's okay. Check fetal heartbeat again, So I think normally the next routine visit, whenever that is for you, would be a good time to check. And I take a note of what side the CL is on, so it's easy to go back to it, and what I've observed, and then we can revisit. You can't remember all these cows, but if you get the guy to jot it down, what's been seen and why, and then it makes sense, and also it shows you're interested and involves you with your client a bit more as well, which is, I think, a good thing.
Okay, thank you, Peter. That's great. We've got a few more coming in fairly quickly now. Bear with me because I almost can't keep up with them.
That's okay.
Following on from that last question, we've got, how about using a CL for embryo transfer but with large lacunae? Do you have any concerns with that?
Yeah, I don't mind as long as I've got more than 5 mil of the wall. I mean, in general terms, what do I look for? I like to see, I think, I like to see more wall than lacuna. If it's a 50-50, I'll give the farmer a choice. To be honest with you, actually, what I always do, I give them a little squeeze, and if they pop, they're no good. If they remain as they should, and I've got more than 5 mil, I'll use them. As a rule of thumb, I like to see more wall than lacuna. And if it's 50-50 or less, I start reconsidering my options.
Okay, thank you.
That's okay.
Then we've got somebody who's just starting out with a curvilinear easy scan and would like to know if you recommend learning to use it by introducing the probe by hand or by using an introducer, or both.
Okay, so that's a very interesting question. Thank you. I believe that there are different parts of the world where I think we do things differently. Now, I spent some time with a New Zealand vet, and what you're doing there, you're doing a high volume of work at great speed, and you can't get in and out quick enough. You need to use a stick basically, but you're determining pregnancy of a large number of animals all in one go at the end of the breeding season, and most of them are very big pregnancies, so they're easy to see. That's the only time I would consider it appropriate to use a stick, because I feel it's important, as I've explained to you, to be able to feel as well as scan. When I'm scanning, I'm trying to maintain excellent contact with the scanner head as I pop it through the ring and into the rectum, and then I've got one finger on the top and the other finger sort of guiding in my thumb where I am. And very often what I'll try and do is just gently flip that uterus up a little bit as I'm examining it, so I am feeling and scanning all at once. So my hand is very much an important part. Now, normally I can scan around all the different structures. Sometimes I even have to let go to pick up the ovum and get it out of the bursoscope and then scan it accurately. So I believe your hand plus your scanner is a good idea to enable you to be able to manipulate things to your advantage at the same time as you are scanning.
Okay, that's really, really helpful. Thank you, Peter. There's a question which I was also almost going to ask myself as well. Is it possible to abort twins as you would do in a horse, so by popping them?
No, unfortunately it's not, and that's a common question. No, the thing is that the equine fetus is much bigger, much sooner. I mean, they're massive. I mean, when you flush them, you can see the 7-day thing coming out at you, whereas the bovine embryo at that stage is microscopic. And the thing is, by the time you've got to the point where you can scan them, the allantochorine's already joined up. So if you squish one, I think the other one will go. I think it's been tried. Whereas with the equine one, you're doing it very much earlier, and you can push one, it hasn't joined on at all, you can push it right to the distal end of the horn and squish it there and leave the other one safe. So no, I don't think you can do that, and I wouldn't advise it.
Okay, thank you very much. We've got another one coming in. What tips would you have for students interested in doing fertility work in the future?
I think good luck. The bar's getting ever higher, isn't it? And I think that you've really got to be a great enthusiast for this work to be able to do it, and you've got to have a high skill level. I think you need to be very enthusiastic, and you need to be determined and go out and get it. I think you need to be aware that it's no good being a rectal tourist, okay? Any fool can go out there and stick their hand up a cow's backside, okay? But I want you to be better than that, both in your scanning, but importantly, alongside my scanning, I'm monitoring all the farms. I run a farmers club for my veterinary practice. We analyse the recorded data every month. We look for nutritional early warning signs of energy stress. I'm looking at the poo, I'm looking at the environment and management, everything. So the umbilicus of our work is through doing really good fertility work to a high standard. But you need to see the whole jigsaw puzzle, okay? It's no good going along just saying, yes, oh, we haven't got very many PDs this week positive. What's going on? Too late, mate. You missed the boat. A month earlier, you should have seen the protein intercept going down. There's not enough protein in the milk. Hang on, guys. The energy's dropping. Why is that? Hang on, it's getting hot. But yeah, we must look at the whole picture to be able to advise the farmer to get fertility right. You've got to get everything else right on the farm. Nutrition, management, welfare, all this stuff. And so when you're doing this work, you're very lucky to be able to be doing it. But bear in mind, it's no good just going off the farm and all you've done is shoved your hand up a cow's backside. I want you to be involved in the whole thing. And to do that, you need to look at data, you need to look at the cows, and you need to stop, you need to go and have a look at the fresh group, you need to go and have a look at the close-up group, the transition cows, the dry cows, all this stuff. So try and look at the whole picture, and then you may have an opportunity, as well as do your fertility work, share your enthusiasm with your client, and get more involved with the whole thing. Work as a team member with the nutritionist, with the consultant and yourself in a way to provide a really good service for your client. And in that way, they'll want you to do their fertility work. And I wish you the best of luck with it.
Thank you, Peter. I sense a lot of passion with that answer. That was a great answer. Thank you so much.
Sorry, yeah.
The next one we've got is just regarding counting of follicles and heritability. By next generation, did you mean that the heifer calves off that cow will have a poorer fertility if the dam has stress in the first 100 days, or the dam herself will have poorer fertility?
No, it seems to me that, well, this is what I've been told, and this other professor, what he found was that he would link the fertility performance of an individual to the follicular count. And if the dam is stressed during pregnancy, her offspring will be less fertile. There's a fascinating study done with the human population. There's an awful lot of stuff, pre-programming going on, and we see this with the IVF work I do as well. But basically they compared the human population, this was after the Second World War, the longevity of a generation of humans born from the females that were under nutritional stress during pregnancy versus females that weren't because of the war. And the females, I think they're from Poland, were under nutritional stress. There was just not enough food about. Their offspring didn't live as long. They had more heart attacks, diabetes and strokes. So we can clearly see the relationship between stress in early pregnancy and subsequent life, including longevity. And this follicular count was merely a demonstration of the same phenomenon with regard to fertility.
Excellent, thank you. What would be, next question, sorry, what would be your treatment of choice for anestrus cows and for cows running every 18 to 22 days?
Okay, so basically when I've said we need to be thorough in our approach, so I monitor conception rate according to fertility treatments on all my farms, and some of them are better than others, but I've got one 400 cow unit, see them every week, and we look very closely at this, and it's been really useful, and several farms now, I'm working with the RMS group, and we're monitoring that as well. What seems to do well is response to single prostaglandin with observed heat and a cedar sink for the anestrus. So that's my quick answer to your anestrus cow using cedar sink. I'll say a little bit more about it, okay? I think a lot of us are being encouraged to do mass medication for stuff. I'm passionate about this as well. Forget all that, guys. We're already starting to see antibiotics going. The next spotlight is going to be on fertility. I don't want you doing mass pre-sync, resync, off-sync. Forget it. Let's minimize our treatment and make it entirely appropriate. And I do believe the anestrus cow would respond quite well to a cedar sink. So we're using the off-sync with a cedar on top. I've looked at off-sync, and typically on my farms, the off-sync conception rate is the lowest of all the fertility treatments. And I learned a little bit more when I was out in Poland about that. The guys over there are doing all the fertility work, plus they're doing all the serving, and they're using off-sync. I did the routines with them around the barn. Okay. Now what I found there was they check them every week. We're not fortunate enough to do many routines every week, but if you do it, check your off-syncs and see if there's a CL, because often the Polish guys were giving 2 shots of GnRH before they went to a prostaglandin. Why? Because they were scanning the CL. They were finding actually there wasn't a decent CL there yet, needed to get a bit bigger before they whacked it with the PG. And so I think often when we use OffSync, and I have got some files where I checked it, it's worth checking. Have we got a CL? Is she going to respond? No. Well, so cover the odds, give her a CEDAR sync, really. So I'm all for that. But I am for trying to optimize treatment on an individual cow basis. And I wouldn't like to sort of broad brush say, I mean, one of my farms I was going to in Hungary wanted me to give everything CEDAR sync, you know, but I wouldn't do it because I said, no, first of all, observe heat. If you're not demonstrating heat, there's something wrong with your management, and we've got to sort that out first before we start dishing out loads of repro drugs. Sorry, I'm go sidetracking a bit, but I hope that so CEDAR sync is my favourite bone estrus. Sorry, yeah, carry on.
No worries at all. It's all very interesting. Next question. We've got 2 or 3 more to get through before we finish at around 9.
Okay.
Have you found more commercial demand for scanning twins since the introduction of Kextone?
Yeah, don't know is the I think Kextone is something I mentioned. It is something I have used. I'll be honest with you, but I think my clients are teed off with being surprised by twins calving early and falling off the perch really, because they haven't had the transition diet, and they end up the twins knocks them for 6 anyway. Then they haven't had the transition ration, and the whole thing can really spoil the cow and her subsequent lactation. So maybe the drug company promoting that product have been pushing it as well, and great if they have actually. I don't care, because I want more vets to scan for twins, and I think that's a really useful thing to do. I think it's increased. I think actually all the time we're getting better, and I think more of us are checking for fetal heartbeats, and more of us are doing the twinning type thing. And my better clients are real big fans of this, and I'm asking, well, how many am I missing? And I do miss some, you know, everybody will, but I'm hopefully trying to get better so that I miss fewer in the future.
Okay, thank you. I think we've got time for one more. Somebody who's doing fairly high numbers with an introducer in a beef operation at about 81 max, with a 15 to 20 day minimum age, they can see, if they see clear fluid in side-by-side horns, can they be reasonably sure that there is an early pregnancy there somewhere? Yeah,
I'd say reasonably sure, but I would be careful, particularly if I'm a young vet, as I know this is the trap that, you know, it's a very common thing, isn't it? Young vets getting done for, you know, missing early pregnancy and giving prostaglandin. I've been amazed at scanning, you know, non-pregnant cows with that hypoechoic fluid in it. I think, yeah, you're pretty safe, both horns, with a decent amount in. But I would I'd find the fetus, and I'd also, yeah, because you're using an introducer, you're not feeling anything either, and actually it's quite useful to be able to feel the uterine tone and stuff if she's bulling or close to bulling. So I think I would say, yeah, the odds are pretty much in your favour, but do be careful, and I think it's better to take a bit more time if you've got that and find the fetus in a little ticker if you can.
Okay, thank you. I think we can probably just squeeze one more in. Common presence of hyperechoic streaks at 21 to 28 days post-calving. Could this be an indication of subclinical endometritis, particularly if it's in the gravid horn?
I think a hyperechoic streak is where you've got, it's the meniscus of fluid if you want. So I think I'd scan through more of that if I found it and see if I could find any more fluid or stuff there. So the hyperechoic streak, if it's just a little streak in the middle, that indicates a meniscus of fluid, I think. And I think that I would need to scan more, and I'd also actually do a vaginal exam as well. I think, you know, combining all the things we can possibly do gives us a fuller picture. Actually, one thing I forgot to mention in the webinar was actually obviously the blood in the metaestral phase. You know, if you think she's just been bullying, have a look. Oh yeah, there's blood there as well. What treatment am I going to give that one? Oh, I think I'll give a prostaglandin in a week's time. You know, so you know all these things will help you. And I think the observation of a hyperechoic streak should alert you to the fact there might be something there. But I'm not going to say that's diagnostic. I'd need to find a bit more material in that uterine lumen before making that diagnosis.
Okay, thank you. That's very helpful. That's all we've got time for tonight, everyone. So thank you so much for popping those questions through. It's really nice to have an interactive session. And generally, thank you so much for signing in, and thank you, Peter. It's been a really, really interesting evening. For anybody that would like to watch again, the webinar is going to be available to view on our website, hopefully within the next 12 to 24 hours, and it will stay on there for the foreseeable future, so you can pop back in whenever you like. So thank you very much, everyone, and I do hope you enjoy the rest of your evening. Take care.
Thank you. Bye-bye.